Okay, can I? Okay. Why I put interactive? It should be question and answer session rather than pure anatomy as you learn from the book. So, but I don't know how to do it online. I prefer to be face to face so we can actually ask a question around. Only thing is online to ask one by one a bit difficult. So anyway, go through the slide. If any problem, sorry, if any question, yes, you can ask anytime during I present this slide. So why we learn anatomy? Actually, to be better in taking history, to be better on examining the patient, to give a better order for investigation. So at the end, to get a good diagnosis and proceed with whether you need a bedside procedure or you need a proper treatment. So significance of surface and clinical anatomy, as I mentioned, all the reason you learn the anatomy actually for at the end of the day is outcome of your patient treatment. So I don't go to textbook anatomy in detail. So you need to go back and read on your own what actually the incision or the what we call or where is the origin and incision of the muscle, all that, because that is detailed in textbook, where I think clinical anatomy is more on applied anatomy from the textbook to the clinical work. So that's more irrelevant. So this is my content. You have ground anatomy, basic clinical history taking, what a special sign on abdomen anatomy, related investigation and related treatment, and safe measure during your surgery or your procedure based on anatomy. So this is the abdominal. You see the border is diaphragm above, and you have a pelvic brim and a pelvic diaphragm below. So you have lateral border as well as anterior and posterior border. So whatever anatomical defect in the above, which is diaphragm, and below, which is the pelvic diaphragm and the inguinal area, as well as anterior, very rare you get posterior defect, is related with surgical problem. Okay, so this is the dermatome. So the dermatome of abdomen is very important. Later we discuss referred pain from internal organ disease, which related to anterior abdominal or any side of trunk, which related to internal organ of abdomen pain, which is very important when you plug a patient. Patient claim that patient have pain at tip of shoulder. Just now I went to ICU post-op. The patient have a pain at the tip of shoulder. I know that during the left nephrectomy yesterday, there is a most likely collection there. So patient have pain. So we noted that drain is not functioning. So we flush the drain, patient pain resolving. The pulse rate coming down less than 100, about 80. So that's such of thing you should know, because there is applied anatomy. So if you don't know that, then you start to think what happened, why patient have pain at the left tip of shoulder. So referred pain, beside the dermatome, referred pain is also important. So this is a basic layer of abdomen: external oblique, transverse abdominal muscle, internal oblique, and rectus muscle at the central. In between this muscle, you can see there is a few things, yeah, which very important for us when we facing the patient with a disease. We have spillogen fascia, so we have spillogen belt area. So when patient have defect here, you should know this patient have spillogen hernia. So this is also a line where you the difference between the area where you have two layers of anterior abdominal muscle and you have one layer of abdominal muscle when you do incision. Okay. So this is layer of abdomen. The basic layer. Later on, we see when you do different incision, you may cut the different layer of muscle. You start with skin, fatty area, scapula fascia, membranous deep layer. You get a deep fascia, external oblique, internal oblique, transverse abdominal muscle. You get transversalis fascia, abdominal, extraperitoneal fat, and peritoneum. So in this layer, it is very important later on when you repair the hernia, what is mean by inlay graft, onlay graft. So all this based on this layer. So this content of abdomen. So you get in general, there is retroperitoneal organ, there are intraperitoneal organ. So in clinical, very important to know which is retroperitoneal component of large bowel, where is we call intraperitoneal component of large bowel. That is very important to know the lesser sac. Where is lesser sac? Where is greater sac? Where is will later on when you manage given patient, where the patient have pancreatic cirrhosis and other disease very related to this compartment. Sometimes post-operatively patient will have paracolic or retrocolic collection secondary to infection or collection primary peritonitis. So you must know where it's located. So in general, it divides into two retroperitoneal organ. Kidney tak ada guys. Okay, this one ada kidney. So there is a kidney, large vessel posteriorly. There is a what we call pancreas. That's why I say interactive. There is everyone should be asked and mention where is it. Okay, so there is stomach, there is transverse colon anterior to stomach, and there is a lesser sac here. Yes, liver and multiple loop of the small bowel. Okay, so the cecum actually at the retroperitoneal area. So that's why appendix is not widely moved. Based on appendix, will not move. So this is look like when you open up, this greater omentum covered the bowel. When we lift up the greater omentum, there is a few organ you can see: liver, diaphragms, ribs, gallbladder, stomach, large intestine, small intestine, and rectum. So I think detailed anatomy of each organ or each system we already discussed earlier, whether it's with colorectal team or hepatobiliary team. Okay, this is what I mean. A greater sac and lesser sac is more obvious to show in these pictures where it's located, and this one further divide supracolic and infracolic. So atas bawah and bawah bawah. So supracolic and infracolic. So that's why in laparotomy you always heard your surgeon say, oh, there is collection in infracolic compartment or supracolic area. So this is the area where suggests a supracolic, infracolic, and lesser sac. So this is surface mark of the abdomen, roughly like this. The abdomen is further divided by the line here. I think all of you learned in undergraduate, the mid-clavicle line bilaterally, transcervical, and also transpyloric. So very important to localize organ based on this division. So in the right hypochondrial area, the pain may came from the liver or gallbladder disease, right lying area, right iliac fossa. So different organ located in different compartments. So the surface marking is very important. For your exam also is very important. People will ask you to draw the surface marking in viva, in short note, and related organ based on surface marking. So I think the same thing, again, the same thing, only thing is it come out here with the visualized organ. I think just now also you can see the specific organ in different compartment. So although there is a what we call additional division of the abdomen just now, but in medicine, especially in certain countries, they have different division. I just highlight there is other type of division. So if later on you have exam with all senior professors come from outside, they may have different division or different ideas, but don't against them. Just mention nicely what we use is British system where you have a 9 quadrant. So I go for congenital abnormalities of the abdomen. So this is all hernias in the abdomen. You can get epigastric hernia, you can get umbilical hernia. it also can get para-umbilical hernia. So the difference between umbilical and para-umbilical hernia is whether the umbilical distorted or umbilical just lift up. So if lift up by the hernia, usually is para-umbilical hernia. But when the umbilical itself is distorted, usually is a umbilical hernia. So this is, as I mentioned earlier, Spigelen hernia because of weakness at the aponeurosis area between two different muscles. We call Spigelen hernia. This is inguinal hernia post-operatively, inguinal hernia, and femoral hernia. So abdomen will have this congenital or acquired hernia. Incisional actually acquired. So under anatomy, congenital is part of clinical anatomy. So this, I think all of you know what is hernia, which defined as what? There is a sac, there is a weak area, then the content of abdomen can enter the hernia sac, or it can be empty without any content. So this is surface landmark of the what we call lower part of the abdomen. Number one is SCIS. Tak boleh nak tanya ni susah. So I go direct to the pictures. Okay. So you get vein here, femoral artery, vein, and also a nerve. So all is inside the femoral triangle. This is femoral triangle, which is located at posterior or at the inferior part of the abdomen. So you is lined by all this muscle. So the content is here. You get femoral vessel. Sometimes you get femoral hernia because of weakness of this area. So I go back again to this. Okay. So in the inguinal area, whether you get undescended testis, one or congenital abnormalities happen. Undescended testis further divide into whether mild descent or ectopic. Sorry, mild descent divide into ectopic or undescended testis. So undescended, the location of testis is through the same line of testicular descent. Whereas ectopic testis is outside the line of testicular descent, so it can be anywhere. It can be at the root of penis, it can be in the abdomen, it can be in the what we call femoral triangle, or any part of the abdomen. It's away from line of descent of testis. So there is a congenital abnormalities which you can find in the abdomen. Inguinal hernia, indirect inguinal hernia is congenital, but direct inguinal hernia usually is acquired. Okay. So that's hernia from below, which is part of the congenital abnormalities. Hernia above, which is at the diaphragm area, is also can happen in the abdomen. It can have a Morgani hernia, can get common hernia in both the leg and Morgani. So it also can have hiatus hernia, which is sliding hernia at the esophageal area. And it also have agenesis or other congenital abnormalities, which is not common. The common type of hernia in the diaphragm area, in the superior part of abdomen, is Bordeaux hernia and Morgani hernia. Sometimes you get hiatus hernia, patient presented with recurrent what we call gastritis. So when you do in further investigation of the patient have hiatus hernia. Bordeaux hernia is most common. As I mentioned, these two types of hernia is common. Bordeaux is most common, about 70 to 90%. So it should be treated because it can cause herniation of what we call abdominal organ into the diaphragm, into the thoracic area. So Morgani is less common. It happens at the anterior component of the diaphragm. Usually present later in life rather than Bordeaux usually presented earlier during fetalhood or during childhood. So this is sliding hernia, hiatus hernia, slide of the what we call abdomen, the stomach into the thoracic through the side of esophagus, the diaphragm and side of esophagus, piercing the diaphragm. This is another congenital abnormality of abdomen, pattern of Rilke's. You can possibly you already go in through it during genitourinary tract anatomy, but it also can happen where it become what we call umbilical abscess. The collection will be have a fistula to the umbilicus. We also have seen patient with congenital pattern of the teres ligamentum of teres from the liver. So both this uricus and ligamentum teres was attached to the umbilical, and it can be pattern and it can present as an umbilical infection pass under the umbilical. So this is one of the congenital. So there is various form, complete. So it can from above, from the umbilical direct to the bladder. It can be partial, as I mentioned. This is most likely a patient presented with umbilical abscess. Then you noted this blind fold here. You need to excite it by what we call by during using the incisional in the umbilical area. So you also can have cystic like this, but usually the cystic is asymptomatic. This is all congenital abnormalities of abdomen. Another one is more common and usually repair immediately is a emphysema as well as gastrocarisis. So there's difference between these two. One is have sac, another one is no sac with the abdominal content come out completely through the anterior abdominal wall. So further detail regarding this condition and management, I think you learn when you go through the pediatric posting later. So I just outlined the congenital abnormalities of abdomen. So now we go for second part. One just now is anatomy. Now we go for clinical symptom, which important when we learn anatomy of abdomen. One, as I mentioned, is referred pain. So the referred pain of abdominal organ, you need to know where is referred to. Why? Because when you plug the patient, patient was complaining it's not direct or straightforward the pain where the site, the actual site of the organ. For example, I mentioned just now diaphragmatic pain at the tip of shoulder. So patient actually have diaphragmatic irritation because of collection or whatever, but the pain felt by patient at the tip of shoulder. This is diaphragm here. So the heart pain usually we not deal with it. We refer to medical. So esophagus, stomach area in this T6 and T7 area, gallbladder area, and colon in the central part, bladder and kidney in the loin area. So referred pain actually important for us to learn where is it located, because when we club patient, we hopefully we get a better provisional and differential diagnosis to make sure the further investigation focus to what the organ involved. So this is in female because a female have extra what we call ovaries and what we call other organ where overlap with other organ. For example, ovaries may overlap with the appendix. So we need to make sure we carefully examine the patient, carefully locate the area of pain to avoid unnecessary surgery for the patient. So clinical sign. So this, I think all of you know McBurney point. In clinical anatomy, you must make sure able to point where is McBurney point. I think I'm not going to go through detail in this point. If you don't know, I think it's difficult for you to be a surgical team, one of the surgical team, because there's the area where the maximum pain is, and during the appendix, and also when you went to make an incision in the abdomen, you are pointed at this area. So the second one is processing time. As I mentioned just now, the appendix attached to the cecum, and the cecum is retroperitoneal organ. So appendix base is not actually moved. So in female patient, we do Rothstein sign purposely to differentiate between shifting whether patient have appendix on or patient have other causes. Another thing is you do a shifting tenderness in female to make sure that when you press the McBurney point, ask the patient to shift laterally, then the tenderness can disappear. So we know that the ovary most likely ovary have a pathology of ovary rather than appendix, because the appendix base at the McBurney point will not move because it attached to the cecum. So roughing and shifting tenderness done to differentiate between appendix and other pathology in female. Murphy sign, I think again you must know detail how to do what is it, because it's very, very common in clinical practice. I just remind back, this is part of my undergraduate anatomical slide. Okay, greater sign again, the same thing. Another what we call classical finding of pancreatic disease, but usually is not common presented with this presentation, because when the patient usually present at a mild or moderate pancreatitis rather than very severe, causing the retroperitoneal hemorrhage. Same thing again, Cullen signs for severe pancreatic disease, but you need to know now you have the test called what we call unmanned unmanned OSCE. It can come out in OSCE and they ask you what is this. You've never seen it before, then you're not able to come out with the diagnosis of Cullen sign. This is Cullen sign. Where is it? What is the Cullen sign indicated for? So what further investigation you want to do when you see the sign? So all this actually need to be related with a clinical treatment and clinical finding. That's a clinical anatomy. Okay, I put in straight leg rising test. Usually it's very common. You use it in orthopedic, but this is very related to surgery because it associates with what we call Swiss abscess. In anatomy, you learn that Swiss abscess attached to greater trochanter of the femur. So it's cross the hip joint. When you flat the hip or you rise the leg, the patient will have tenderness at the Swiss muscle. When the patient presented with loin pain, positive straight leg rising test, you know the patient is have very severe infection in the retroperitoneal area. It can be perinephric abscess extend to Swiss or in the other way around. Sometimes it can be perforated appendix extend to Swiss. So in anatomy, the incision and the origin and incision of Swiss muscle need to be learned and applied back with this test to make sure you have a correct diagnosis of Swiss abscess. So this is a rectus muscle. I tak sure boleh nampak kan. Okay, the main aim I shows here that when you examine your patient, you ask the patient in the hernia cases, when you ask a patient to contract the rectus muscle, whatever this when the swelling disappear, you can mention that the swelling is originate from intra-abdominal compartment. But if the swelling in the abdomen become more prominent, is related that this swelling actually originate at interior abdominal muscle. That's important of contraction of rectus muscle in clinical examination. So you need to know anatomy to apply this and to give a good diagnosis. So I go for third part, which is investigation applied in clinical anatomy. So when you went to investigate to abdomen area, you have X-rays, you get ultrasound and other part. So I was showing here just on X-ray which related to the anatomy. When you ask the patient to go for X-ray, you must know what you went to find out. If patient have IO, intestinal obstruction, you must apply both because you want to see on erect is fluid electrolyte level. How many fluid electrolyte level? More than 3 is significant. Patient have IO, and you want to see supine X-ray because you want to see side of dilated vessel, dilated bowel, as well as you want to measure the dilated bowel. So very important to have both X-ray. It gives you more information than you get only one X-ray. If you order abdominal X-ray, they do supine X-ray, you're not able to count the what you call air fluid level for obstructed bowel for IO. So this is sorry. Another special X-rays based on anatomy. When you know that patient have perforated hollow organ in the abdomen, clinically tender, patient not able to erect, you order lateral decubitus. So this is lateral decubitus showing that there is a fluid, air at the lateral border of abdomen when patient was put in lateral decubitus. So it suggests perforated of hollow organ inside the abdomen. This X-rays also lateral decubitus, there is no free air, so it's not suggestive of perforation. So that's important. You usually order erect chest X-ray to see the air under diaphragm, but in clinical, sometimes patient not able to sit up because of severe abdominal pain or generalized peritonitis. You can order lateral decubitus and noted there free air under diaphragm. Okay, for the treatment, mainly applied anatomy in treatment for abdominal area is incision. So you must master in all area of incision, type of incision, and what muscle to be cut when you go through this incision. So that is anatomy of abdomen applied in clinical. So you see, I think very familiar with Koch's incision. You get flank incision. So in flank incision, usually apply for open nephrectomy for the benign disease, where we go for retroperitoneal approach, or sometimes you go for open urethrotomy for the large urethric stone. So flank incision have a subcostal, intercostal, and costal incision. So based on tip of 12 rib. So if you start incision from tip of 12 rib, is costal incision. Above 12 rib is supracostal. Below 12 rib is subcostal. Okay, number 3, I think everyone of you familiar with midline laparotomy. Why it go to the lateral? Sorry, it go to left lateral by pusing kiri. It's not pusing kanan. Anybody can answer? Yeah.
Because of the ligament.
Yes, because of ligament trees. That's why I think very important to know just now what organ beneath your skin. So eventually, actually, you will ligate the ligament, but uh, doing when you're doing the incision without knowing what beneath your knife, is very dangerous to injure ligament without tying it. So that's why you go to the left side. If you see, actually, during finding this slide, I have seen various textbooks using on the left side. Apparently, some center, different type of approach they used to be they curve into the right side. But traditionally, with our teaching onto the left because of ligament. Okay. Number 5 is the fenestrial incision. You get lance. You have also get gridiron here. Let's show you later. McEvedy, you know McEvedy incision? This one, McEvedy. Anybody can,
For the hernia.
what type hernia?
Uh, femor
Betul lah tu.
femoral.
Femoral. Okay. Number 9 is paramedian, rarely done nowadays because of a lot of complication, because you disrupt the muscle and you get incisional hernia because of paramedian incision. Number 6 is rooftop. Okay. So in this incision, there is tadi ada lance here, kat sini ada gridiron. Okay, you see the difference between gridiron and lance. Based on your what we call your familiarity, which one you more familiar with, you can do gridiron or lance. Usually people do lance, straight line, more transverse incision, but some people used to do gridiron to get more what we call better look into the scar, because it follow the skin. So here also you get pararectus scar, not sorry. What is Rutherford Morrison incision? Rutherford. Anybody can answer? Sebutlah satu. Okay, this is a layer of abdomen. Very famous question. Ask whatever. What layer you cut? Okay, so you must know each layer. Just now I show you the pictures. Now is in point form. Go detail for type of incision. This is based on where the site of incision. So if you cut upper part of your abdomen, this is the incision. Sorry, this is a muscle and other structure you cut. Okay, you have skin, subcutaneous fat, rectus muscle, external oblique, internal oblique, transversalis abdominis, transversalis fascia, extraserous fascia, and peritoneal. So this part, and if you further down below the umbilicus, you will be cutting more on what we call aponeurosis. And if you go further below this arcade line, you only have one one rectus muscle. So this is all three sides of abdominal incision. You must know in detail what muscle have been cut during the incision. Sometimes if you see just now, you have number 2, thoracoabdominal muscle, thoracoabdominal incision. So if you go here, when we do a thoracoabdominal incision, you should be careful with interthoracic, what we call neurovascular bundle in between the ribs, because it can cause very difficult to control the artery when you incidentally cut it without ligate earlier, because it retracted below. So the neurovascular bundle in the rib have been run at the groove of the rib at the lower part of the rib. So make sure can be identified and ligate before proceed with further thoracoabdominal incision for the esophagus surgery. Okay, so far this is very important slide. Ambil je lah, simpan, hafal. It's very important slide for you now and when you work as a surgeon later. It's not only for exam, but actually when you apply the incision, choose the incision when you do a surgery, you know a definite anatomy what you are dealing with. Okay, the next slide is option. What option of incision you can use when you are dealing with the pathology of the abdominal organ. So esophagus, as I mentioned just now, usually people can do what you call thoracoabdominal approach. Okay, upper thoracic ni biasa terbuka abdomen. So abdomen, left thoracoabdominal approach or rooftop incision, but usually rooftop incision for the esophagus is a bit difficult to reach if it's higher or either proximal part of the esophagus. So for stomach, usually we use a rooftop. Depend on preferable of the surgeon. Rooftop will have advantage of dealing with short gastric artery which entering the what we call spleen on the left side. But if you do upper midline, you have problem to reach the area because that area is far lateral. Okay, the liver still the preferred area is rooftop. But certain surgeons still use a laparotomy to handle the liver. But depend on anatomy, depend on disease, where is it located. If we are dealing with a resection of left liver lobe, maybe the midline have a good exposure to the left lobe of liver rather than rooftop. But rooftop in the right liver lesion is easier to approach the liver lesion. So biliary tree Koches is the best incision, as you know. Pancreas, still rooftop. Some people use the transverse. Duodenum, Koches is a name when you what we call dissect the duodenum or mobilize the duodenum. So Koches procedure is when you mobilize it. So Koches incision can be used. Some people call right subcostal incision. Small bowel, I think appendix, as I mentioned, you get various incision. Rectum, okay, this is all kidney, midline also can. We used to use a subcostal incision for the intraperitoneal approach for the kidney. We also used to be flank incision for retroperitoneal approach for the kidney. So in infection disease, we go for retroperitoneal approach with flank incision. In tumor or trauma, we go for intraperitoneal approach with subcostal or midline incision for the kidney. Okay, I think that's all. We go for this is all my content for clinical incision or the other safety measure. When you approach to the abdomen incision, the what we call the safest area to enter the abdomen, actually, as you do regularly the laparotomy, is a subumbilical incision. Below the umbilical, some people used to open the supraumbilical, above umbilical, depend on whether you want to do midline, lower midline or upper midline. So lower midline, you approach to the subumbilical area where not many what we call structure will be located beneath it. But when you want to do midline, upper and lower midline combination, upper umbilical also good area to approach before you open the peritoneal area. Flank incision, the safest area flank incision actually located at the tip of traffic to develop retroperitoneal space in the flank incision. The safest area in anatomy before you establish the retroperitoneal space without entering the peritoneum is at the tip of traffic. So that's how we used to open the retroperitoneal area for kidney, for the adrenal surgery and other, usually kidney and adrenal surgery. We approach retroperitoneal or retroperitoneal space to open up space and deliver the organ. So we open at the tip of traffic. I think that's all my slide. Any question?
Right, any question from the floor, from online attendees? Prof. Nestle, I've got a question actually on mass closure. So
Okay.
So sometimes when you do appendicectomy and then you divide the muscles, I mean, most of the appendicectomies that we learn are anecdotal from seniors. Jadi sometimes people say, oh, repair the muscle. Sometimes people say, don't repair the muscle, just close everything. So what do you suggest is the current current practice now?
I don't know. I'll teach you anatomy only.
Right, okay.
Okay, I give you anatomy answer. Sorry. Yeah, I find back my slide. Sometime. Okay. When you do incision at the right iliac fossa area, sometimes actually during incision you what we call ligate or burn as many as a vessel and a nerve. So it weaken the area rather than how you close. So it not heal well and form later on incisional hernia because you already what you call necrotized or minimum sorry, not minimum, maximum control of blood vessel, and then you give problem with healing the area. So whether you repair or not the muscle, if you split, most of the time no need to repair because you don't actually cut the muscle. You split the in between the rectus before you enter the peritoneum, so you don't cut the muscle. So actually no need to repair. That's why some people don't repair it. So the main issues with healing is because of what we call ischemia to the area, because ligation and what we call ligation, and also you burn the nerve ending in the area. So that's the main reason.
All right, Prof. Thank you. Any other questions? I think that's we've got no further questions from everyone.
No further question.
No
We
further
can
questions.
end up our session.
Thank you, Prof. Nazli, for joining us on a
Okay,
Saturday
welcome.
at 4 o'clock. I think this is a very important topic, and definitely will come out during our exams.
Yeah. All this slide will come out. Either one of the slide will come out as your Viva.
All right, Prof. Prof. Haris is asking whether we can have the slides.
Boleh ambil je lah.
Boleh, Haris.
Okay, thank you.
Okay, thank you very much, Prof.
Welcome.
Okay, enjoy the rest of your weekend.
Thank you, Prof.